Hola y bienvenidos y bienvenidas el día de hoy. Es un gusto para mí dar inicio al segundo año del Seminario Web, Salud Mental e Intervenciones Emergentes. Este es un evento que se organiza desde la Facultad de Estudios Superiores Iztacala de la Universidad Nacional Autónoma de México, a través del Laboratorio de Psicología e Innovación Tecnológica LabSIT y del grupo chat Comunidad de Habilidades y Aprendizajes con Tecnología. También en colaboración con diversas universidades del país, el Instituto Tecnológico de Sonora, la Universidad Autónoma de Baja California, la Universidad Autónoma de Ciudad Juárez, la Facultad de Psicología UNAM y la Secretaría de Salud del Estado de Tlaxcala. Este es un evento que surge en el marco de un proyecto de investigación titulado Idoneidad, Utilidad Clínica y Aceptabilidad de una Intervención Transdiagnóstica vía Internet para el tratamiento de trastornos emocionales y derivados del estrés y el trauma, y que es financiado por FORDECID, PRONACET, Salud, de CONACYT y por PAMPI. Les doy la bienvenida a todos. Este año se ha cambiado la estrategia, ya que además de las ponencias tendremos un foro abierto para que los asistentes participen, por lo que para ser acreedores de su constancia de participación tendrán que asistir a la ponencia y participar en el foro. Mis compañeros les estarán compartiendo las instrucciones del foro en unos momentos por el chat y también por correo electrónico. Le damos la bienvenida al Dr. Bouman. Hi, and welcome to the first conference of 2022 in the webinar Mental Health Assessment and Emergent Interventions. It's a great pleasure for me to introduce our speaker today, Professor Dr. Theo Bouman. Dr. Bouman is an associate professor of clinical psychology at the University of Groningen in the Netherlands, and the head of the postmaster training program for healthcare psychologists in the North Netherlands area. In the latter position, he is responsible for the content, implementation, and national policy of this government-accredited training program. His main area of interest is experimental psychotherapy, with an emphasis on the assessment and the development and evaluation of cognitive behavioral treatment of anxiety disorders and somatoform disorders, especially hypochondriasis, body dysmorphic disorder, and emetophobia. This also includes cross-cultural aspects of clinical psychology, and in particular, cognitive behavioral therapy. He has authored numerous papers, books, and book chapters on these topics, as well as many workshops, invited lectures, and media presentations. At the University of Groningen, he teaches a wide variety of courses in the Bachelor, Master, and Research Master programs of the Department of Psychology. In addition, he is the coordinator of the psychology module of the European Erasmus Mundus Master Program Network on Humanitarian Action, NOAA, thereby acting as a visiting academic at the University of Gadjah Mada in Jakarta, Indonesia. Internationally, he regularly gives lectures and workshops on the area of his expertise in, for example, India, Sweden, Spain, and Malta. He is registered healthcare psychologist, cognitive behavioral therapist, and a distinguished member of the Dutch Association of Behavioral Therapy and Cognitive Therapy. Thank you, Dr. Bouman, for accepting our invitation and for joining us today. Dr. Bouman is going to be sharing a presentation on the cultural adaptation of cognitive behavioral therapy. And without any further ado, I'll leave you with Dr. Bouman.
Thank you very much, Alejandrina, for this brilliant introduction. First of all, I must express my gratitude for the invitation by you and all the staff of UNAM. I'm very happy with that, because it basically is my first kind of live interaction with your university, apart from, of course, our bilaterals, etc. And of course, it also, let's say, stimulates me to pay a visit to Mexico one day. Because I must admit, I mean, I've been traveling around, but Mexico was not on my list yet. But now it's very high on the list for many, many, many reasons. And some of the reasons will become apparent during my presentation. So I'm very happy to be able to share something. The idea is, according to your program, to give a presentation, and then you, Alejandrina, will collect questions and remarks on the chat, and then after the presentation there will be opportunity to have some exchange of thoughts and to see what we come up with. Because listeners and viewers, I can warn you, this will not be a presentation with a clear ending and, let's say, the knowledge of, well, this is what it is, because it is kind of open-ended. And as you might guess, cultural aspects in clinical psychology and psychology in general are in a way a kind of a niche market, because it's not so prevalent as it should be. And we come to that in a minute. So what I'm going to present to you is some ideas and some broad outlines that are related to cultural adaptation of cognitive behavioral treatments. We just did some dress rehearsal when it came to the slides, and I suppose you now see my second slide, just testing. Yeah? Cool.
Yeah.
So imagine you're a psychologist and you're sitting in your office in your private practice. You have your treatment manual published in the US of A on your desk, all prepared, and at the same time, right in front of you, there is this patient from a nearby village. How does it combine? That's the big thing. So, and that is also one of the things that I like to explore a bit more with you. And if there are any questions, as you might have learned already, I'm very happy to answer them or to get your opinion on some aspects after my presentation. So this is the whole thing. On the one hand, you got your treatment manual. This is how it should be done. In this case, a workbook on depression. And on the other hand, a real patient. So what are the issues? Before we dive into the exciting world of cognitive therapy and of cultural adaptations, it's important to realize a few things that are, let's say, quite determining for our position, for our attitude as clinicians, and maybe also as researchers. Because, I mean, if we start from the top down, then we should realize what mental health entails. And mental health, according to WHO, is a state of well-being in which the individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. That's quite something. One remarkable aspect of this definition is that it doesn't refer to the absence of illness. It is rather formulated in a positive sense, that you are able to contribute, to realize your potential, basically. That's an important thing to remember, to realize your potential, to make a contribution to your community as a patient. So it's very personalized in a way. And as clinicians, but also as researchers, who are basically supporting clinical practice, clinical thinking, clinical knowledge, it's our moral obligation to provide the best care possible. It sounds a bit like an open door, because many people would argue that, of course, we don't want to provide the worst care possible. But then the question is, what is the best care? How would we define best care? And for that purpose, it's important to realize that it's not just a matter of, well, let's say choice, but it's basically our moral obligation. Because if you don't know the evidence, if you don't know what you're doing, you might actually do harm to your patients. For example, by not providing treatment in an effective way, just messing around, or withholding effective treatment by, for example, offering treatments that are not efficient or that have not been proven to be efficient. So in Latin, the term is primum non nocere, do no harm. And to expand a little bit more, this can be seen from the point of view from evidence-based medicine, which we can translate to the psychological domain as evidence-based mental health. So it is the application of, it's the conscientious, explicit, and judicious use of current best evidence, so there you got the evidence, in making decisions about the care of individual patients. Or stated differently, is the integration of best research evidence with clinical expertise and patient values. So there you can see basically three elements: evidence, expertise, and values. And in a schema, it would look like this. And these three circles all represent the three components: scientific knowledge, clinical expertise, and patient preferences and values. And it's the integration and the triangle in the middle that basically constitutes evidence-based mental health. And this seems a far cry from cultural adaptation of cognitive behavioral therapy, but during the presentation it will become apparent that this is exactly what we're aiming at. Why is it important to be aware of this, let's say, holy trinity, as you might say? It's important because it helps you to profile yourself as a psychologist. Because if you know what you're doing, if you know what the evidence base is, if you know what your own abilities are, and if you know what your patient wants, then this increases your self-confidence. It also makes your position among other healthcare workers very clear, because what is a psychologist doing? And I guess it's a bit the same situation in Mexico as in the Netherlands. If you would ask people in the street, what is a psychologist? Hardly anybody would know. Most people would think something like psychic or somebody who can read your mind, who can see right through you. So the more explicit you are about your own abilities, about your own knowledge, about your own domain, the better other healthcare workers such as doctors, psychiatrists, nurses know what they're at when they are confronted with you. If you profile yourself, if you make noticeable what you are and what you can do, it also increases your credibility with your patient. And if you are able to express yourself in a clear way and in a convincing way, this increases patient motivation. Because treatment motivation, for example, is a kind of 50-50 process. It's not just a characteristic of a patient, but it's also in part attributable to the clinician. So if you're able to actually present yourself in a convincing way, have a good story, so to speak, then it increases patient motivation, but it also manages patients' expectation. They know what they can expect. And very important for psychologists all around the world, if you position yourself as a psychologist, if people know what a psychologist is, credibility vis-a-vis policymakers, insurance companies, politicians, and whatnot is also increased. So it's important to be able to express your expertise, your domain, not only to yourself, but also to other people. And there is even a political issue involved. So this is a bit like the background. Thing is, maybe just to sum it up, thing is, what is CBT? And I think most of the people who are listening and watching right now know the basics of CBT, or maybe even on an advanced level. And the important thing to realize is that it's an empirically based form of treatment. It's based on theories on mechanisms, on effectiveness, and it's not just a set of therapeutic interventions. Some people think that CBT, cognitive behavioral therapy, is something like doing exposure or doing cognitive techniques or doing imagery rehearsal or whatever. That's not the case. It's basically applying theoretical models, perspectives, information, empirical evidence to your patient. The big thing is, and we'll go into that into more detail in a minute or two, basically, it's a difference between the box and the content. I mean, you can sell and you can present cognitive behavioral therapy in many, many ways, but that is a bit like the box. And there are many boxes, but the main thing is what's in it. And many so-called new fashion therapies basically are a box containing solid cognitive behavioral intervention elements. So the presentation might differ, a very fancy tea box or a very cheap cardboard box, but the content of CBT is basically the same. And it relates to psychopathological mechanisms and what we know about this, and our knowledge about change mechanisms. And when you think about the cultural adaptation, the cultural application of CBT, this makes it a bit more understandable what its purpose is. And of course, in its simplest form, it's about thoughts, feelings, and behaviors. It's a very simple way of presenting the basic tenets of CBT. How these thoughts are manifested, how the behaviors are showing themselves, how people express their feelings might differ. How to change these also might differ. But in its very simple form, the basic idea is just this little triangle. And you're also aware of the fact that characteristics of CBT are its focus on the present, the question, why does a problem exist? The already mentioned thoughts, behaviors, and emotions. It is focused in time, in goal, and in orientation like problem solving. So it makes this a very nice package. If you would ask people who are not very well aware of CBT how they think CBT relates to clinical problems, then most people would say CBT applies to simple problems. For example, specific phobia. In the Netherlands, everybody is talking about spider phobia, for example. Maybe there are also specific Mexican examples that people would come to mind. But over the course of time, over the course of the decades, CBT stretches influence into more and more complicated problems like personality disorders, substance abuse, complicated disorders in which more than one diagnosis applies. If a patient is suffering from schizophrenia plus addiction and is homeless and has violence outbursts, that's a different story. And nowadays, CBT is more and more being applied to people who are maybe not even willing or able to benefit from it, like people with a criminal background in a criminal or forensic setting, or people with low IQ or brain damage. So from a very focused set of procedures, CBT kind of proliferated into, well, almost all kinds of human problems. And this is not a story to sell CBT, because you can be very critical about that, but it shows that there is a huge development over the past, let's say, almost 60, 70 years. Many ways to deliver CBT. Traditionally, it's been an individual treatment, one therapist and one patient, but the manners in which CBT can be delivered are also vastly exploding. Internet deliverance nowadays on apps. If you are exploring your App Store or your Google libraries, Android store, then you find a lot of mental health apps which basically are built on CBT principles, because CBT principles are, in a way, rather easy to communicate and rather easy to translate into do-it-yourself approaches, like do-it-yourself apps. So this is just a little summary of how CBT has developed over the past decades. That's the nice part of the story, but we could go into all these aspects in far more detail, but then we would have a webinar of about a week or two. And well, that's not going to happen. Because there are also buts, there are obstacles. And some of the obstacles is that some patients find CBT difficult to understand. From the clinician's point, it might be very simple and straightforward, but some patients find it difficult to grasp for whatever reason. Some therapists might also find it difficult to grasp the ideas of CBT, still thinking, for example, that it's a specific set of interventions. And one important thing is also that patients and therapists might not be the match made in heaven. For example, because of differences in cultural backgrounds, differences in socioeconomic backgrounds, difficulties and differences in intellectual background. So in principle, CBT is a very nice, straightforward, effective treatment, but, so the big but word is something that we should explore. And that's also one of our obligations, so to speak, as clinicians, but also as researchers. And because if something is rather difficult to understand or presents us with a problem, of course, as clinicians and researchers, we become totally excited and we want to know what is the problem and how can we solve it. If we look at CBT, then, and of course, you've also been reading about this as you're watching this presentation right now. And one of the things that might struck you is that many of the books that you've been reading, a lot of literature, were either in English or have been translated into Spanish, but they have this kind of Western cultural ring about it. So this raises the question, is CBT really a kind of worldwide approach? Or is it something that is restricted in its background philosophy and in its application to so-called Westerners? Because many people tend to forget that CBT has been developed and is still developing in a number of contexts. There is a historical context. In the European tradition, you remember people like Pavlov, and the American tradition like Skinner, and many, many more fathers and fatherless mothers of learning theory, for example. There are historical developments, scientific developments. Nowadays, fashionable paradigms are cognitive models. It's all about cognitions, it's about brain function, etc. Whereas in the 1970s, there was more attention for systemic approaches and the environment than it's nowadays. There are also differences in philosophical, economic, and cultural approaches. So CBT is not something that's totally culture-free. That's what I want to convey with this slide. It's embedded in a lot of cultures that are also interacting. And one of the important cultures that we are going to address right now is the cultural context. Because CBT has been developed in a Western context, but is it a Western approach? Well, that is something that you might argue about. Maybe it's nice to ask a question about it later on, or to present your ideas about this. But interestingly, CBT has been developed in Western countries. And it's a matter of how do you define Western. You might argue that is Europe, United States, Canada, Australia, New Zealand, maybe. But that's about it. It also means that maybe, and it's rather speculative, but that also the description and the emphasis on certain types of problems or certain types of psychopathology also is embedded in Western culture. For example, patients from Ethiopia, they might complain about snakes nibbling at the inside of their skull. Snakes, imagine snakes nibbling at the inside of your skull, in your head. For a Western psychologist or psychiatrist, this might sound like, at least psychotic. There are no snakes in your head. But it's an Ethiopian way of expressing that you are worrying a lot. So the description of problems, the whole conceptualization of problems that are basically the focus of CBT are rather Western. And also the psychological mindedness of the recipients, of the patients, of the clinicians. The psychological mindedness, you are a kind of computer-like machine. That is how the mind works, that is input, information is being processed, that is output, relates to a kind of psychological mindedness. And CBT is also embedded in a more or less Western healthcare system, where in quite a lot of countries, mental health care is covered by insurance companies. That is something that we should not underestimate in its importance. So that's the developmental part, and it also is embedded in when it comes to how Western is CBT. There are also quite a number of mostly implicit Western value systems and values. For example, independence is highly valued, and I think maybe in my country, the Netherlands, even more so than in your country. It's all about, well, if you would put it in a rather black and white manner, it's all about me, myself, I. I should be independent, I should grow, I should be happy, I should be rid of problems, and other people are playing less of a role. And it is quite different from many other countries in the world. I would argue almost 80% of the world population are living in a kind of culture where interdependence, interrelatedness between people is far more important than independence. And in the Western value system, you can also see that the emphasis is more on a secular or worldly set of values than on spiritual or religious values. If you read about CBT, religion, spirituality is hardly mentioned. Some people connect it nowadays, for example, connect Buddhism and acceptance and commitment therapy, one form of third wave CBT, with each other, pertaining or even pretending to give a kind of spiritual edge to CBT. But then again, it's a kind of a Western translation of an Oriental belief system. And also very important, the effectiveness of many CBT treatments, interventions, packages, treatment manuals have been mostly tested in Western countries. So the big question as a researcher, you might ask yourself, how about the external validity? Would these treatments also be equally effective, and would they also apply in non-Western countries? So that's a whole set, basically a whole research agenda that we should follow. And they relate to the questions about universality. Are the so-called Western theories of psychopathology universally valid? Does it apply to everybody on the globe? Is there just one most efficient type of effective therapeutic relationship? The way the therapist and the patient should interact? And does it also apply to intervention techniques? Are all techniques equally effective or more or less equally effective all across the globe? Same with acceptability. So these are all issues that are very relevant for global mental health. If you want to, and that's a macro political issue, if you want to increase mental health across the globe, which is basically part of the United Nations Social Sustainable Development Goals, SDGs, Sustainable Development Goal 3.4, which states that everybody is entitled to mental health care and having a good mental health. So the question is, do all these kind of treatments that we are and have been developing in the Western world, are they beneficial for people across the globe? So it's a macro political issue that we are addressing implicitly here. And there are huge cultural variations. So this kind of counters the assumption that everything that has been described right now in clinical psychology, in psychopathological papers applies to everybody across the world. because there are many explanations of the origin of problems. And where does it come from? How do people present their symptoms and syndromes? I already mentioned the example of the Ethiopian patient who complained about snakes in his head, snakes who are nibbling the inside of his skull. That's quite a different vocabulary than many people in, for example, Europe would use if they would be worrying. They would talk about worrying, I can't sleep, I'm very upset about things, etc. So less vivid, less prosaic. Symptom expression, how do people express their symptoms? There's a lot of literature suggesting that, for example, patients in Asian and Southeast Asian, South Asian countries are expressing their unwell-being much more in somatic terms than in behavioral and cognitive terms. Whereas even if you watch talk shows, I mean, if you watch American talk shows, everybody's talking about their thoughts and their feelings, etc. So this kind of symptom expression, sense of unwell-being, is expressed in a more cognitive and sometimes even behavioral and violent way. And then again, apart from that, there are also differences in theories of healing and the interventions that come from it. So how should we heal? Should we have a chat with somebody who is called a therapist, or should we solve our problems in a more collective way on the square in the midst of the village? Should we seek our refuge to a spiritual leader, or what? So all these, and the same also interventions. So this points to the fact that there are many, many differences in the way in which people are experiencing problems, in which they express problems, and in which they basically seek solutions for their problems. So now we're confronted with two problems. On the one hand, there is a huge body of evidence that a lot of treatments, cognitive behavioral treatments, are effective. They have been proven to be effective in a lot of sometimes very expensive and very lengthy studies in the Western world, mostly from the United States. So on the one hand, you might wonder, there are many differences between people all across the world. On the other hand, you might wonder, okay, but there are also there's a lot of evidence that treatments are effective, for example, in reducing depression. So why would you change? Why would you adapt treatments to culture? Well, basically, you can depart from 3 points of view. You would want to make, and now we're talking about CBT, cognitive behavior therapy, you would adapt it culturally in order to make it more acceptable for patients. So what is acceptability? How do you make your patient embrace the idea of this particular treatment? Acceptability is one. Accessibility. How can patients reach treatment facilities? And sometimes reach is literally used. How could they get to the place of healing, and to the clinic, for example? In large countries such as Mexico, and I'm not sure about this, so I'm not going to give you an example about your country, but I can imagine that some people are living far away from hospitals or from clinics or from any other places where they can find mental health care. So accessibility is really a problem. And also, who's going to pay for it? Accessibility has therefore many aspects that are really practical obstacles for some people to get the mental health care they might need. And so accessibility should be an issue when it comes to cultural adaptation, and also its effectiveness. Is it true that, let's say, standard or mainstream cognitive behavioral interventions are less effective for people with different cultural backgrounds? And now we're talking about people with a non-Western background. Some of them might live in Western countries. Nowadays, all across the world, we see a huge amount of people who are being displaced, resettled, are fleeing from their own home country, and they are settling in a new country in which they form a minority. But the same thing also applies to people who are actually living in their own country. Miriam Lommen, who's also one of the presenters in the previous version of this webinar, and myself, we formed this kind of, very small team of travelers across the world. In one of our trips to India, for example, we were struck by the fact that India, with 1.3 billion inhabitants, is such a culturally diverse country. So if you talk about Indian patients, you still don't know what you're talking about, because in a huge country, and the same applies to China and to any other huge country, there is such a diversity in cultural aspects, excuse me, and background, that even there, cultural adaptation could be something that's seriously to be considered. And there are also contextual factors. It's not only about the patient and the therapist. There are huge differences across the world in healthcare system. The role of professionals, what kind of professionals are delivering healthcare, how many psychologists are there? And to give you an example, in India, with 1.3 billion people, which actually is quite a lot, to say the least, there are something like 1,000 psychiatrists. So if you would quickly calculate it in a proportion, that it's next to nothing. So 1.3 billion people with 1,000 psychiatrists. A similar thing applies to Indonesia. That's a country where we're also doing research. In Indonesia, 270 million people, and there are only something like 3,000 clinical psychologists. And mostly they are concentrated in, let's say, the affluent urban areas. So many people can't be reached and can't have any access to healthcare systems, and let alone because they can't pay for it. Because many people who are living in non-Western countries don't have this, let's say, very generous coverage of healthcare issues that are being seen in, for example, the Netherlands. In the Netherlands, we are paying a lot of money per month because healthcare insurance is mandatory, but then in return, almost everything's been covered. Whereas in, for example, Indonesia, hardly anything has been covered. So if you are a depressed person in Indonesia, at some point you have to pay not only the healthcare, but you also don't earn any money whilst you are in consultation with your psychologist. So these are really very important things to take into consideration. Same like the socioeconomic factors like poverty and societal exclusion. And interestingly for us as researchers, these are elements that are hardly included in treatment outcome research, because they all focus, most of them focus on the happy few, the rich people who can afford going to a psychologist or a psychiatrist, getting treatment, are able to pay for it, and are living in relatively protective circumstances. So there you can see that there is something like psychology, psychopathology, and politics interwoven. If you want to read more about this, it's not a very expensive book. It's a very nice, a very critical book, in which the author Ethan Waters makes a case, or basically demonstrates, that psychopathology is also being exported from Western countries to non-Western countries. Many examples. For example, how depression has been marketed in Japan. In the early 90s, hardly anybody in Japan was suffering from depression, and then inspired so to speak, by the pharmaceutical industry, depression was put on the map, and now it's a huge market for antidepressant medication. Very interesting book. I think it's only about something like, well, $12, so that won't set you back too much. Important to read and important to realize the global context of everything that we are studying, try to understand. So the thing is, at some point, we are considering to make adaptations because we want to reach patients rather than leaving them alone, or rather than presenting them with unacceptable, inaccessible, and ineffective treatments. So what kind of adaptations are we considering? And then scholars are basically debating about this because on the one hand, you could see the cultural adaptation as a continuum. On the one hand, some people argue that one should just deliver treatments Western style with no adaptation at all. For example, EMDR or imagery exposure for post-traumatic stress disorder. Some clinicians and some researchers state that it should be delivered just the way as it has been developed. And quite a lot of them also find very beneficial results in patients with different cultural background than the original groups in the outcome studies. On the other hand, there are also clinicians who state that basically you have to start developing new treatments, also incorporating indigenous elements, basically resulting in total adaptation. It sounds very nice and very patient-friendly and very culture-friendly, but on the other hand, maybe you throw away the child with the bathwater, because then, in that case of designing a treatment totally from scratch, you also have to do all the effectiveness studies from scratch. And maybe that's a bit too much. So as usual, maybe also the solution is somewhere in the middle. A little bit of tweaking, but not too much. A little bit benefiting from the already existing database of the effectiveness of interventions, but not totally relying on it. And if you look at potential candidates for adaptation, then on a surface level, the treatment format is something that can be changed, modified, adapted. Language for one. It's not only the translation from, for example, an English language treatment manual into Spanish or into Dutch, but it's also the level of language. How complicated should that be? And also things like the use of metaphors and to make it more come to life for your patient. Same with verbal and visual materials. You can draw pictures rather than giving somebody an instruction leaflet with 20,000 words on it. And it's also important in some cultures to include family members in the treatment. That in a Dutch situation, for example, in my country, that would be, well, a bit special. But I know with our experience in India and Indonesia, for example, including family members in treatment is basically the common way to go. And then it's also a matter of if you deliver services, where do you do this? In a healthcare center, at home? Do you do this online? It has a huge potential, online treatments. And should it be done by a professional or by a lay person? Should the professional or the lay person be very directive, or should it be more on a kind of equal foot? So there are many candidates for treatment adaptation. And basically the strategy would be from bottom to top to determine, based on empirical evidence, the most effective treatment components. For example, when we talk about anxiety disorders, it has been well established that exposure in vivo is a very powerful intervention. So would that be something that can be used? Or in the case of anxiety disorders. In depression, for example, behavioral activation is the way to go. It is one of the most effective treatment interventions. The thing is, would you just offer that to your patient? Well, maybe the next step would be to develop this treatment in a local style. An example would be behavioral activation for depression. As you might know, behavioral activation consists of stimulating the patient to undertake action, to do things, not because they like it initially, but to give them the sense of mastery. But what would you stimulate the patient to do? Well, this has a lot of cultural and local and maybe traditional aspects in it. In the Netherlands, people would, for example, start running around, buy their sneakers and start jogging, go out and do some sports or walk the dog or whatever. One of our colleagues in Indonesia, for example, found that walking the dog in Indonesia is something that's totally unheard of. Most Indonesian people don't have dogs, and dogs are also considered to be a kind of impure animals. So people don't do things with dogs, and they certainly don't walk their dog. So that is something that requires adaptation to local style. It's also important to check patient acceptability. Do patients, after the drawing board, do patients actually accept this kind of treatment, or is it something that they dislike? And only after these stages, psychologists can be trained and treatments can be implemented. The thing is, if you would envision these kind of adaptations, do they really matter? So is there any kind of evidence? Well, in a way there is. There is some evidence, and most evidence is rather inconclusive or rather mild when it comes to support for cultural adaptations. Because in this meta-analysis or systematic review by Chaudhary, for example, it appeared that most of the adaptations were in the dimensions of language and context and the delivery of treatment. So not very complicated adaptations. It didn't appear that whole CBT needs to be revised from the bottom up. And this was also something that was found by Hall and colleagues in a large meta-analysis. He also found that cultural adapted versions or interventions were slightly more effective, but on the other hand, unadapted versions were also effective. So it was just a matter of a few points on the scale. And also more recent meta-analysis by Schneier-Rathold and colleagues, there it appeared that at least there's a great variety of adaptation factors, again, language and concepts, etc. But also that most of the studies have been done in America and Western Europe for immigrant populations. So there is really a need for more studies of potentially effective treatments, CBT, mostly for in non-Western cultures. So the good news is that on the one hand, these kind of studies are increasing, there are more. On the other hand, it's rather unclear how and why we should adapt CBT in a cultural manner. And it's also quite remarkable that religious and spiritual elements are often not included. Whereas, and that's also my picture what I got from Mexico, for example, religion plays a great role for many people in daily life. And that's what we see for the 1 billion people who are, for example, devout Muslims, and the 1 point how many people who are Christians. And so it is quite amazing that the value system that is being aspired by these religious by these religions are not included in CBT. So when it comes to how to do it, I'm not going to give you a long list of how to do it, but I give you some suggestions. When it comes to cultural adaptation in practice, then a very nice book to read is this book by Shania Rattled and colleagues, rather recent. And in this book, quite a number of cases are being described, showing how to adapt your CBT effectively to your patient. So it's more, let's say, case-based book than something like a meta-analysis or a systematic review. And it shows that an important point is the clinician's willingness to understand the patient. Of course, that sounds like an open door, but the willingness to understand the patient from a cultural perspective, rather than assuming that because a patient has a dark skin, then he should be from a country from Africa and he should be poor, etc., etc. So cultural stereotypes are something that the clinician should be aware of on the one hand, and on the other hand, it is also important to be aware of the patient's perspective on the clinician, because patients also have an idea about clinicians, and these ideas from the patient's point of view might be real obstacles in treatment. It's a very interesting book, so I'm now into the reading list recommendations. And another interesting thing, because the book by Ratholt is basically intended for clinicians, a very interesting thing as well is a development by the World Health Organization, Problem Management Plus treatment protocol. And this treatment protocol is basically CBT light, you might call it, delivered by lay helpers. So people with all kinds of non-psychological, non-professional, non-academic backgrounds may be trained in this program, and they may become lay counselors. And why is this important? It is important because it brings CBT, it brings effective treatments or approaches within the reach of people who are in very unfortunate situations. And it's a very brief, manualized kind of treatment, 5 times 1.5 hour sessions, homework assignments, and it goes from managing stress to managing problems to managing your depression, inactivity, to strengthening social support, up to relapse prevention. And there is by now quite a lot of research done and going on in non-Western countries, in refugee camps, for asylum seekers. So this is a way how to bring CBT, how to bring effective treatments to people who are in dire need of it. Our own example consists of several trips to Indonesia, where we also, Mirjam Lommen, my colleague, and myself, are exploring Indonesian mental health care. And there we found quite a lot of things, in particular the collective society and its impact on people's sense of well-being and unwell-being, and also the spiritual and religious values and beliefs that are pervading daily life. I'll skip this one. So what we actually did do was thinking about and discussing with our Indonesian colleagues about the accessibility of cognitive behavioral therapy. How can we improve this? What should be done? And one of our first steps was basically to try to find out if CBT was acceptable for Indonesian patients at all, because you could just design a lot of interesting interventions, but if they are unacceptable for patients, if patients don't like it, if patients feel that they are actually clashing with their personal, family, and religious values, then there is no point in delivering treatments. So what we actually did do was to design CBT Indonesian style. We made a lot of video clips and in which CBT interventions were demonstrated, and then we presented these to patients and to mental health volunteers, and then we found out these video clips. Then we found out that patients actually found the interventions that were being shown quite acceptable. Very long story, but our conclusion is that basically Western-style CBT interventions can be presented in such a way that they are acceptable for local healthcare consumers. And the only thing that we did in our video clips was change the language, change a bit of the wording to make it more understandable for Indonesian patients, to present it not by Western psychologists, but have it presented by local psychologists who were very knowledgeable and well trained in these matters. And that already did the trick. So that made CBT acceptable for Indonesian patients. So to sum up, back again to square one. Why are cultural adaptations important? Well, because of this, we might call it holy trinity of evidence-based mental health. So it's not only about scientific knowledge, it's not only about clinical expertise, but it's also about patient values and preferences. And there you see cultural backgrounds of patients resonating. That's why it's important to have a clear eye on the patient's part, on the clinician's part, and how skillful are they in, and how cultural sensitive are they in delivering treatment to people with a different cultural background. That's one thing. And the other thing is, luckily, the increasing evidence for the acceptability and the effectiveness of treatments that don't vary too much from treatments that are being delivered in the West, the Western part of the world. So, point of departure and start is that we should adapt treatment to people instead of adapting people to treatment. We really should bring treatment to our patients. Increase accessibility, increase acceptance, and increase treatment outcome. That are the goals, and that is the way how we can ensure that the Sustainable Development Goal of the United Nations might be reached someday. Thank you very much.
Thank you, Dr. Bouman, for a very insightful presentation. We've been receiving some questions and comments from our guests. Our guests would like to thank you for sharing your knowledge, for reminding us of these aspects that are important to take into consideration when adapting interventions in culture, and how essential it is to ask ourselves about the universality of CBT, especially because of how culture not only models behaviors, but values, and also political insights. In Mexico, there are some parts of the population that do not have accessibility to psychological treatments. We have a question from Diana. In your opinion, should the permanent training of psychologists look to discuss the basic principles of CBT limited to cultural adaptation?
That's a very good question. So should we, you mean should we incorporate cultural adaptations in training?
That's right. And discussion.
Yeah, that's a very good point. And I think we should, because, well, in my opinion, and that's also what I see in my country, and I'm not, of course, I'm not knowledgeable about Mexico, but very often treatment, hence CBT treatment, or whatever kind of treatment, it also may apply to psychodynamic or person-centered treatment, is conceived as a kind of one-size-fits-all, one T-shirt that should fit everybody. And you know, if we would sell XXL T-shirts, I mean, some people would for some people it would fit nicely, for other people it would look ridiculous. And it's the same with treatments. So these cultural aspects are so very important, because in culture, you see the person's values resonating, and values are kind of undervalued, so to speak, in CBT. But values are the things that make people come into action. Things we find important, things that are basically what we want out of life, are our guiding principles. And these guiding principles are very much embedded in culture. If you, I mean, if you travel around, you meet people, then in some cultures, it's very important that people stay close with their family, that they do what their father wants them to do, etc. Whereas in other cultures, and this filial piety, being connected with your family, is far less important. So if you forget about this, and I think it should become more and more part of training. This is a long story with a short ending.
Yeah.
That's a very good question.
Isabel wanted to know, she was wondering about CBT as a Western approach. You point out on your review of concepts that can be taken for granted. Can you give us examples?
You mean the points in CBT that I got the chat on my screen as well. So the Western approach, and pointed out, taken for granted. Well, for example, I've read some literature, and I've discussed quite a lot of these things with people with an Islamic background, Muslim, so to speak. And interestingly, what we are take for granted when we are doing CBT is that we are basically the master of our own thoughts, the master of our own destiny, etc. You want to fulfill your own expectations, realize your own things, and you are the one who's basically controlling your thoughts. Whereas in Islamic uh, people with the Islamic faith, they see God, Allah, as the one that is basically judging them, that is basically determining their fate to a certain point, which is totally different from the CBT point of view. So this whole idea of what your position in life is, and you might say in CBT the position is more horizontal, and people amongst each other, whereas in Islam, and maybe it also holds for many other religions, there is also a vertical relationship. Interesting example is, for example, that patients with social anxiety disorder, and they think about themselves as being inferior to other people. They are afraid of the negative judgment by other people. In Islamic view, the idea is, and that's also part of an Islamic take on CBT, the idea is, who are you to judge yourself? Because there is only one who is judging you, and that is God. It's rather different from the usual CBT approach, where you have to challenge your thoughts about what other people think about you. So these concepts are taken for granted, and that's all kind of horizontal, non-spiritual.
Okay, I think we have time for one more question. Javier wanted to know, does context factors as bureaucracy role for delivering intervention or economic resources are part of the scope of cultural adaptation?
That's a very good question, because it points to the fact not only of the clinician and the patient in the consultation room, but it relates to the wider context. And it is something that is very often forgotten by psychologists, by psychological researchers, because they think, okay, there's somebody in the consultation room and that's where it happens. But most part of patient's life is happening outside of consultation room. So if you are confronted with poverty, if you are concerned about your job, if your housing is very bad, I mean, it has a serious impact on people's psychological functioning and even on psychopathology. So that's also why we should pay much more attention to that than we do nowadays. So contextualizing, that would be the word, contextualizing CBT, I think that is one thing that we should do in the very near future, starting now. Very good questions, by the way.
Well, unfortunately, the time we have is limited, and however, you can contact Dr. Bouman for more questions on the subject or to follow
Sure.
his work. I once again would like to thank you, Dr. Bauman, on behalf of all our guests, the UNAM community, Dr. Annabelle, and me for having accepted our invitation to join us to this webinar.
And thank you for your kind invitation. I really would have loved to be there in person, and then we could have a drink right now. But of course, I mean, probably next time.
We should plan that.
Sure.
Thank you, Dr. Bauman. I'm going to switch to Spanish right now. Y bueno, antes de despedirme, quería recordarles que además de las ponencias, tendremos un foro abierto para que los asistentes participen. Se les enviarán las instrucciones por correo. Quería invitarlos también a los asistentes para la próxima sesión del seminario web. Será el 28 de marzo. Tendremos invitado al doctor Edgar Landa de la Facultad de Psicología. También quería recordarles que sigan nuestro canal del laboratorio, que activen la campanita para que no se pierdan ninguna de las ponencias y que este webinar estará durante todo el año. Las ponencias son el último lunes de cada mes y tenemos excelentes invitados. Muchas gracias por su atención. Thank you again, Dr. Bauman. Hopefully we'll see you in the near future.
Thank you very much. Have a very good day.
Have a very good afternoon for you.
Thank you. Bye-bye.
Bye.